And what's actually happening and what they address in the video is that when the video was made, there was still a requirement that all the states join the new Medicaid expansion. And with the Supreme Court ruling, that's no longer the case. So some of the numbers they had at the end are going to be off. So the $32 million estimate of the new cost is going to be off. Or the $32 million was referring to the increase in the number of insured people. That's going to be off because some states are going to choose not to opt in, and so the insurance is not going to spread as widely in those states. Also, the $938 billion in new expenditures is going to be off because the federal government is not going to be sending money to help out the states that are not doing the expansion. Also, I think there's been some new estimates on what exactly it's going to do to the deficit. So just those numbers at the end of the video kind of take with a grain of salt, but the rest of the stuff talking about how the expansion works and the rules and regulations that go along with it are still valid. So this is the most up-to-date map that I have on the decision of which states are going to join the expansion and which aren't. Basically, the ones that are in red decided that they're not going to participate, and blue is choosing to participate in that expansion. And basically, if you choose not to go to the expansion, you can stay at the same levels that you're at currently in your state. You can change somewhere in between. But if you don't go along with exactly what the federal government's saying, they're not going to increase the funding that they're sending to you to help you pay for it. So how has the ACA already started working, and what kind of results have we seen from this? So from the increased age limit, where you can be 26 and still be on your parents' insurance, they've shown that over 2 million young adults have gained coverage, like they've gone back and been like, hey, I can get back my parents' insurance now. So that's contributed to the decline that we've seen in the number of uninsured in America. Insurers can no longer turn down kids for pre-existing conditions. Currently, they still can for adults, but that's going to change next year. So for Medicare beneficiaries, there's a Part D that's kind of the prescription drug plan. And in the past, there's been this donut hole. So the problem was, up to, say, like $2,500, they were helping you pay, like, for your prescription drug plans, and there was a gap between like $25,000 and $5,000 where you weren't getting any help, and then from $5,000 and above, they were helping you again. And so they've been trying to close that gap, and so the Medicare beneficiaries have had about 6.3 million using money somewhere in that gap, and it's saved $6.1 billion on prescription drug costs for those patients. We've also seen some of the preventive care starting to become available. So free immunizations, certain free screenings, some of your checkups and stuff that you have to have annually are free now. One of the things that's actually been one of the most popular for the public, in public opinion, is that they have to provide this summary of benefits and coverage. So the insurance company has to provide this to you. And it gives you kind of a consistent information that you can compare different plans from different companies and stuff, because they're all using the same form, and it makes it so much easier to understand the policies and know what they're covering, what they're costing you, just kind of knowing what you're getting into whenever you buy this plan, because some of them can be so long and complicated that an average person reading it isn't going to know what they're reading. So this sheet makes it much easier for you to understand and buy your own insurance. The lifetime limits are gone on what you can spend. That's already been taken out. Annual limits are slowly being phased out, so allowing the insurance companies to kind of adjust for it as they go and get to a point where they have enough funds where they don't have to worry about there no longer being annual limits. And they mentioned the insurance administrative rebates in the video. And this is the amount of premium that you're paying to your insurance company. They're saying that between 80 and 85% of that actually has to go back out in health expenditures for your policyholders. You can't be spending 40% of the premium that you're taking in on administrative costs or CEO salaries or taxes, profits, anything like that. So you have to actually use the premium money to treat your patients. And if you end up not using that amount of money, then you have to give money back to the consumer. And we've already seen about $1 billion going back to consumers as a result of this. So some other things that it's going to be doing. We have the Hospital Readmissions Reduction Program. So that one in particular is looking at hospitals that have higher than expected readmission rates for Medicare. And if you're above that threshold, then you're going to get decreased payments for all of your Medicare patients. So you won't get paid as much unless you're getting the appropriate outcomes and not getting crazy numbers of readmissions. There are going to be Medicare penalties in the payment for hospital-acquired conditions. So they're saying like the top 25% of hospitals as far as having things like bed sores, falls, things like that. They're kind of accidents or issues that come along with the hospital stays. Those are going to have to pay penalties for having those items at above a certain rate. And they're also offering bundle payments for renal disease patients. So instead of paying for dialysis every time you have to go in for it or whatever other treatments you're having to have, it's a lump sum payment that's paid, and then they have to treat you for the issue that you're having with your renal disease. So as far as accountable care organizations, I mentioned before that there were like 400 something. About 200, 250 are under part of the ACA that are done for like this Medicare program. And what they're saying is that you have to have more than 5,000 Medicare patients, and you have to manage them for 3 or more years. And they'll provide a bonus to you for keeping the cost down and meeting quality benchmarks. And this kind of estimate that is supposed to save Medicare about $5 billion over 10 years, instead of paying for individual episodes, just giving the lump sums. So this is a projection. The top line, the blue line, is the spending without reform. The green is the expected spending with reform, and this is just for Medicare. And you see like over time that the gap between them is getting larger. I mean, it's up into like $100 billion in 2019. One thing to note is that since this was made, we actually got the numbers for 2012. And where we have the 571 there, it was actually lower, it was 551. So we're actually getting decent outcomes, and that may not all be from reform, but this is like, the trend is going down further than it was previously. So a couple of other things, I've mentioned several times that they're going to do the optional Medicaid expansion, and that's going to be financed by the federal government. The state health insurance exchanges, which I think the video explained pretty well to you. In that, they're going to have the subsidies for the individuals that are having to buy insurance from it. That's based on your poverty level. You may be on a sliding scale. But again, there's going to be no public plan. Small businesses get a tax credit. The employers with 50 plus have to provide or pay a fee, and the individual mandate for the penalty for individuals who don't have coverage. So this is the estimated effect. So a couple of years ago, this looked a little more impressive because we were talking about Medicaid being required to expand. Now we're only looking at 2014, maybe a drop between 2012 and 2014 of about 3% in the uninsured. And you can see like 2% is going to exchanges, and they're not expecting but a 1% change in the number of employees receiving insurance through their companies. So another thing that was presented to the Supreme Court was whether the mandate was legal or not, and they determined that yes, it was constitutional. But why would we want to mandate health insurance coverage? Basically because there's adverse selection in healthcare markets. There are a lot of people that can afford insurance and just choose not to. And if all individuals are insured, then we expect that your premiums are actually going to fall. So this idea of adverse selection, we have this cycle that goes on. You have the health insurance company setting your premiums, and that's based on the expected cost. And then at the next step, you have people choosing whether or not to buy insurance. So you're definitely going to have the sick people buying. They're going to benefit from it. And they're going to be healthy people that buy it as well, if it's at a reasonable cost to them and think, yeah, it's worth the payment to cover my risks. And so then you have the average risk and expected cost. Well, the more healthy people that opt out, the higher the expected cost for the insurance companies. And so that's going to raise the price of your premiums, which is going to make more healthy people opt out and raise the premiums again. And it just kind of goes in this cycle and kind of unravels out of control to where no one's able to afford insurance. And this is particularly important when they're saying that they have to accept people. Because at that point, it's like they're no longer able to mitigate those costs by saying, well, no, you're too sick, we're not going to pay for you. So the health insurance premiums just get higher and higher and higher. So we also have the problem of maybe having free riders if there's no mandate for them to buy. So you have customers who think they're going to be healthy, and so they just say, well, I'm not going to buy health insurance, I'm not going to worry about it. But how many of these people could actually afford insurance? So there was a study that showed about 53% of the population were in households earning less than 4 times the poverty level. And of those, they estimated that about 17% could afford health insurance, but were just deciding not to buy it. And they based affordability on public options and private options that are available to them, because there's actually like a surprising number of people who could get Medicare or Medicaid and just never fill out the paperwork. So the ACA requires insurers to sell policies regardless of health status, and that's going to be in 2014. Without a mandate, these persons that have decided not to buy could just be like, oh, I'm sick, I guess I'll go out and buy insurance tomorrow. They can't tell me no. And so they're not paying into the company, but expecting a payment out. Mandating relatively healthy people to purchase health insurance will bring the average premiums down. And that's going to be the same thing as that cycle that I showed you before, but just whenever healthy people are required to buy, the risk is lower for the insurance companies, so the premiums aren't going to be as high. And part of the reason that's going to keep the premiums down is that 85 to 80% that they're required to spend on healthcare, otherwise give a rebate back to you. So how is it fair that you're requiring everyone to buy? Medical care is really more inevitable and more costly than you realize. 57% of the 40 million uninsured in 2007 used medical care that year. Uncompensated care reached 43 billion, and in 2010, we had the health expenditures per capita of about 8,000. And another issue that we run into is like whenever you don't have insurance, whenever you have, like a respiratory infection or something like that, you're not going to see your primary care physician. You wait until you're really, really sick and then end up in the ER. And so it ends up costing so much more just on average. So how does the US compare to other countries? So we have much better outcomes for several things. We have better mortality after heart attack, we have better cancer outcomes, but we have a lot of lower ratings for other items. So we have lower patient satisfaction. We rank 15 out of 19 in preventable deaths prior to age 75. We're the last of 23 in infant mortality, and this is just looking at the developed countries. This isn't everyone. But we're also tied for last in life expectancy after age 60. So a lot of times like this argument's made, it's like, well, we're paying so much more, but we're really getting a lot for it. Our healthcare is so much better. But that's just not what the data shows. There are certain things that are, but there are many things that are not. So even though we spend more on healthcare, our performance is not necessarily better. Yeah.
Is there a reason for why we're last in infant mortality?
Not that I'm familiar with.
I'd just be curious. That's just intriguing to me. I don't know why more than any of the other stats, but do you have I think some of the preemie care that we have.
Do we try and save infants that other countries wouldn't try and save?
I would imagine that might be it.
That is definitely a possibility. It definitely is. But I can't give you a really good answer. I'm sorry.
No, that's okay. I was just curious.
My specialty is cancer. Let's see. So we have the highest admission rates for asthma, congestive heart failure, and diabetes complications. Now, some of that I think can be blamed on our public, not necessarily our medical system. I think a lot of us just don't take the care that we should of ourselves that is seen in other countries. And we have greater than median admission rates for CPD and hypertension. So why should we be worrying about this? Okay, so I already mentioned that the costly premiums are raising the number of uninsured. Employees receive raises in terms of health insurance contributions instead of higher wages, and we all know we want more money in our pockets. Excess growth in health costs reduces employment, output, and value added, because as those insurance premiums go up, they're less likely to hire new workers because they're going to have to pay for insurance for them and their wages, and it just becomes very excessive. But why haven't we complained more in the past? So we don't really notice the foregone raise. So when our insurance, for instance, changes here at Rice, it may go up, like $10 a month for me. And then you see Rice is paying, much more per month in the following year. But that's money that technically could have gone into my pocket as a raise, but instead they're spending on my health insurance. Also, employer-provided health insurance is exempted from taxes. So whenever your employer is shopping for insurance that they're going to offer to the company, since they get to count as a tax break, they're not necessarily looking for the best deal for you. They're more likely in the HR office thinking, I'm just going to pick the plan that's going to have the less people coming in here and asking me questions or having issues with it or things like that. So you're not necessarily getting the best deal. And we have a blind trust in doctors because medicine is so complex. We don't know whether we need the test or not. We don't know what the best option is. That's why we go to them. So rising healthcare costs can become detrimental to U.S. businesses. Costs are still likely to increase unless we change the payment incentives for health providers, unless we encourage them to do, higher quality care instead of just doing everything in the book. And we need to be more aggressive in our cost control in that sense. So we live in a remarkable new age. We have these new technologies, we have longer life expectancy, we have better quality of life. And these things are all great, but they're all contributing to our healthcare cost. So we need to reform the coverage decisions, reform provider payment in order to just ensure that everyone is getting some kind of high quality costs for the most people possible. So the ACA is going to increase health insurance coverage in 2014 at its most dramatic point. We haven't seen the biggest of the bill yet. The mandate is going to reduce the free rider problem, and in theory it's going to reduce our premiums as well, which is going to be great. It's going to devote substantial resources to improving insurance coverage while restraining cost growth. When we cross our fingers. And this is just something to kind of end on. It doesn't really matter which side of the debate you're on. I really feel like you need to proofread your signs before you go out. Just going through different web pages and you see things kind of pop out at you, and I thought some were humorous, so I hope you enjoy it. Is there any other questions?
I looked at the infant mortality question, and
Oh, thanks.
it is, well, one of the sites I found just said that young mothers with no access to health care might be part of the contributing factor that we have for the low income, and generally poorer women with no access to health care. And so birth rates are not monitored properly.
Thank you so much for that. Yeah.
In your opinion, are there more efficient ways that we could go about saving on healthcare costs? Because it seems like all of this chips away at a larger problem,
Mm-hmm.
but it's just, inch by inch and we're treading miles. And it seems like initially a lot of the Patient Protection and Affordable Care Act was developed to increase access to care,
Yeah.
but they used insurance as the end of a means, not means to an end, and not using it as a tool to really develop that. So do you feel like with all these new potential influx of patients going into the system, that'll make the system, it'll be a larger burden on the system with operational efficiencies and things of that nature?
So that's been a concern for a lot of doctors. You're gonna have this crazy influx, in about a year. Luckily for them, it's not gonna be as large as they anticipated, because I think most of it that they were worried about was gonna be the Medicaid patients, particularly here in Texas. Our low income level that you have to meet is much lower than a lot of states. So the change, if we had accepted, was going to be very dramatic. One thing, I don't know if you recall the slide with the two pie charts that showed the difference in uninsurance. You can go back to it if you want. But it was showing that maybe it was only going to be like 3% between 2012 and 2014. So the growth isn't going to be as large as it was initially thought.
So there'd be
So it's going to be a more gradual thing without people accepting that increase for that one program. It's going to make a big difference. And they are already working on the health exchanges, trying to get them set up and stuff, and try to work on the behind the scenes for that. A lot of states are doing it by themselves. Some of them are just going to take, the federal is making kind of a setup that you can take and use within your state, which I think as of now, that may be what Texas is doing, talking about maybe just working off the federal basis. But basically, the growth isn't going to be as dramatic initially as thought, so it's not going to be as much of an issue. Your question on whether this is actually going to, curb cost, or if maybe it's the most efficient way, I think that's the main problem. And one of the reasons that this bill is so big is because no one knows what's actually going to work. Even looking at different countries, just the mentality of our country is so much different than most of them that have more effective healthcare systems, that we can't say, hey, we should do this. This is definitely going to work. It's like, that's the problem, is no one actually knows. And so it's kind of like the first few years are going to become this trial and error basis. And that's where a lot of the comparative effectiveness research is going to come in. Because in those first years, when these different programs are being implemented, it's really key that we have people looking at the numbers and doing the research and saying, hey, this is working. No, this isn't. We need to get rid of this. This isn't really doing what it's supposed to do.
And do you also think that these provisions that are being placed help the reimbursement issue with Medicare and Medicaid? Because I understand that program wasn't supposed to be sustainable for generations, right? And so where everybody's running out of money and all the cynical doctors are up in arms because they say they can't even turn the lights on in their offices if they were just to take those kinds of patients. Yet those kinds of patients, the sick and the poor, are probably more often, you know, the majority of the patient population. So do the like bundle payments and pay for per performance, things with those measures, do you think that will help cover those costs or?
So I don't necessarily, no, I think that those will to some extent. I think what's gonna do more help for those, for like the Medicare program in particular, is some of the stuff that they're doing that I didn't talk about. So they're restructuring some of like their reimbursements and stuff in other areas and deciding what they're gonna cover and what they aren't and things like that. And those are gonna make more of a difference than what I've discussed. Yeah.
So, what do you think like the reason is when, as you said, US is compared to different countries and like they're not able to adopt this kind of systems, the effective healthcare in other countries, why like even though giving so fancy like health coverage and all sophisticated machinery and all the facilities, why the patients are still unsatisfied, there is no good care or infant mortality rate, and still it's lagging behind even after these benefits. Like, so, and on the top of that, you implement such a complex bill system that people are not able to understand. And as they had the problem before, that there are unforeseen costs, hidden costs. So how do they expect they will be believing in this new reform?
So, are you asking like how to get the public behind this type of thing, or?
What's the like public perception? Are they satisfied with these kind of new things? Like,
Oh yeah, it's very split, very split.
are they thinking that okay, these things that are like low satisfaction, these high mortality rates, are they going to change after all this is implemented? What's public thinking?
So this bill focuses a lot more on cost. It does have a quality aspect. So hopefully you'll see something in those measures. The primary concern right now is cost though.
Yeah,
So that's what it's-
It's always talk about like getting all of the people insured and like managing the cost on one part of the public so that it covers everyone, so that they don't have to pay that high.
Yeah.
For the states that are not participating, is that going to affect the patient long-term in terms of health quality or not?
So basically it'll leave them exactly where they are. What it's gonna do is prevent people from getting insurance that they might be able to get in a different state. I think being uninsured does affect your quality of health because it's so expensive to get anything done. You're wary of getting any care at all. Usually when you do get care, it's way worse than it was if you'd have been able to afford to go to the doctor initially, because majority of the uninsured are also low income. So it's not like, you know, it's the richest person on the block and they chose not to get insurance and they can still go pay for whatever they need. That's usually not the case. So, yeah, I think lack of insurance is definitely affects your quality of health. Yeah.
What will be the federal government reaction to those states that will not, that are planning to opt out?
Basically, their relationship won't change. So if you opt in, you're going to get a lot more funding in order to cover the new people that you're bringing into the program. But if you opt out, you'll just stay exactly how you are with the relationship you have on that program.
Looking out, even they are not following the federal laws to provide the coverage for everyone.
Well, because the Supreme Court told them that you can't require them to do it, that it has to be a state option, because you're basically, I mean, the program that they're expanding is state-run and federal-run, and so the federal government was coming in and saying, hey, we're going to expand it, and you're all going to expand it too, and they told them, no, you can't do that. You have to say, we'll help you if you'll expand it, you get to choose. And so they're not allowed to like put any type of penalty or anything on states that choose not to do it. Anything else? Yeah.
Besides pay for performance and bundled payments, do you not think that price transparency would be more of a driving factor, so you know exactly what your costs are? And why are we not going towards regulating or setting a baseline of services that have an actual price to them?
So I think price transparency is important. But it's going to be more important to people like you and me than it is to the whole population. So whether you're going to have the time or the means to do the research and find out, you know, hey, this company charges this much for this hospital charges a different rate, and then be able to base your decisions on that is the question. So if it's like traumatic care or something like that, it's not going to affect, they're going to go to the first place, you know, the closest place regardless of price. I was actually in a meeting earlier this week, and Dr. John Middleton was in there. I don't know if you're familiar with him. But he said, just, you know, off the cuff, that in the past years, there have been a lot more people actually like calling hospitals and going, hey, what do you charge for this, and comparing. And so there is some sort of a movement towards that, and they are offering that information, but it is a shame that you can't like go on and search it somewhere or find it on your own without having to do calling up and be like, can you give me an estimate? I agree that it would be very helpful. I mean, there is nothing in these reforms that pushes towards that direction, but I was kind of interested to hear that people are actually trying to do something on their end as well. Yeah.
Well, it seems hard to say that you wouldn't have time to do that because people do that for hotels, they do that for airports, and I feel like it just needs to be more transparent and more organized online for people to look up, and that would be a huge savings in costs and like bend the curve of costs, because then people would finally be able to see that and it would make it a more competitive market.
Yeah, I agree. I'm sorry if I wasn't clear. I was just mentioning like for like traumatic things and stuff like that, you wouldn't have the ability to search. But yeah, I agree. I mean, I'm a crazy internet searcher for everything I buy, everything. I'm a bargain hunter. So I definitely agree with what you were saying. Yeah.
In support of what she just said, I think they should make it clearer, because my first time here in the US, I bought one, I didn't know what the deductible was, so like 2 years I didn't use them. So when I wanted to use them, they told me the deductible was $5,000 that they can come in, but I had to buy it because it was cheaper, so I didn't know the implication of all those stuff.
Right.
But when I realized, I had to change them, so they should make all those things clearer so that you know what you are going into before you sign the contract and stuff like that.
I was going to say, for that, they actually are doing something. So for the cost of your insurance, not for the cost of procedures and stuff, but for the cost of the insurance, that was what I was speaking about. They're making this form that like all insurance companies have to use, this standardized description of the insurance that you're buying that explains all your costs, all of your benefits and everything to you. So in a way that you can easily compare different ones and know what you're purchasing. So that is something that has been implemented. Yeah.
In previous readings, with regards to the OECD data, I think that's where you got the some of the stuff from. And, I think I remember making a correlation that we spend 3 times the amount on healthcare than the next country, yet our costs, or excuse me, yet our quality of care is you know, not on that same parallel. What do you think is, in regards to cost, the thing that we can chip away at the most? Because it seems like even though this bill was framed to help save costs, if you invest at, was it like 900 billion to get 1.2 billion, 124 billion back? Mm-hmm. That's I mean, in the private sector, I would assume that probably wouldn't be a good investment. Like if you were a pharmaceutical company and you switch those numbers to millions, that would not be your Lipitor or whatever drug that, you know, the blockbuster.
Right. So your question, or are you commenting?
No, I apologize. So what do you think? So what do you think is the largest thing that we can take care of with regards to costs?
Okay. I think one of the largest things is going to be giving the right incentives to physicians. I think there is a lot of like excess testing and stuff that are, expensive testing. Maybe just they don't have access to the guidelines that they should have access to, getting the information to the doctors so that they know. I mean, they do so many different things, especially as like if you're a general practitioner, you have to know so much about so many different items. It's like, how could we get the information to them so that they know what the best procedures and the best steps are to take, instead of having to come in and look at, a patient and be like, well, I've tried this before and it's worked, let's try it. Things like that, or just having uncertainty and so running tests instead of just cutting through and getting right to some sort of treatment or something like that. So just incentives and education to physicians. If y'all are out of questions, then I'm going to be finished. You're good.